Quick disclaimer before you listen. The World's Okayest Medic Podcast is an educational and commentary platform produced and recorded by me. What we say on here is not endorsed by any of our employers, and we are not speaking on behalf of our employers. Our commentary is our own. Finally, remember to follow your local protocols. All right, so I'm here with Dr. Bert Schiffer. This is a monumentous occasion because you are the first person who has ever flown in to be on the podcast.
Happy to be here.
Yeah, so I just went to the airport and picked him up. You want to give some background?
Sure.
Quick.
I'm a recovering paramedic of approximately 20 some years. Love being a paramedic. Still love going out in the field. I realized that I wanted to do more from an airway perspective, and the only way to do that was either become a nurse anesthetist or an EMS physician, and ultimately became a EMS physician and an emergency medicine physician. And now I get to actually do RSIs in the field, and most importantly, get to support other people as they learn how to do that, as in Pennsylvania, it's coming down for paramedics as it should.
So you truly were one of those paramedics, like, airway is my identity.
Oh my God, yes. If you couldn't get a tube, then we all looked down on you at one point. And that was what it was back a couple of decades ago.
Gotcha. And you're now a medical director.
And
That's how I got to know you, because you also worked as an ER physician at the community hospital where I used to transport patients to, that has since closed down. And
yes.
you live and breathe EMS. Like, I would say that is your calling. Like, you're all about it.
Very much so. It's about leading a good team and giving people the ability to do their jobs and get out of their way when they're being successful.
Yes. So I wanted to bring up, to start, a comment that I have seen pop up on social media and different threads a bunch of times that I don't agree with, but I kind of understand how paramedics and EMTs get frustrated. And the comment I see is that we need to get doctors out of EMS. Like, we shouldn't have physician oversight. And I don't agree with that. And I'm not just saying that because you're a medical director and you're sitting here in my basement studio. I know we've talked about this a little bit, you and I, but what are your thoughts on it and the importance of having physicians involved?
I absolutely see both sides of that, and I know where it comes from. There's a lot of physician oversight that is not EMS focused, and it's from people who think that if you're not a physician, you shouldn't be practicing medicine in any way, shape, or form. And I think just about every paramedic has been told, don't do anything, just drive into the hospital. That's the last thing any paramedic ever wants to hear. It's not about who's in charge, it's about the collaboration. It's really about how that physician integrates themselves into the clinical care, how involved they are, and what their goal of being involved is. The paramedic is the top line EMS provider in the United States. So the question shouldn't be how do we limit them, it's how can we empower them? And where I see the physician in that is taking the system of medicine, not just the practice of individual emergency medicine, but understanding how the whole system comes together. And then in collaboration, coming up with safe protocols for the paramedics to move forward with. Where I see a lot of physicians have problems is seeing low-performing paramedics doing
that
questionable practice and thinking that that's the standard, and it isn't. There are phenomenal paramedics out there who really provide excellent, insightful care to their patients. And we need to find a way to allow that to become the standard. So where I see the physician medical director is finding, training, and supporting those excellent clinicians and allowing them to fly. And I don't just mean on a helicopter. I mean fly clinically, provide excellent care at the roadside where the patient needs it, not where it's convenient for the physician.
Yeah. How do you balance wanting to collaborate and raise the bar, but also not be one of those medical directors? Because we all know they exist, that just cater to the lowest common denominator. Let me set up my system so they can't screw things up. How do you balance that? Because that is a real
I want to get half a step back.
Okay.
So one of the things I do at my full-time job is sit down with every new employee the first day that they start with us, wheelchair vans to critical care nurses, And I tell them, you're going to screw up. I anticipate you're going to screw up. That's not the issue. The issue is, do you own it? Do you come forward and share it? And do you help make it better so the next person doesn't do that? I don't think that people won't screw up. I think they will. And I say that in a positive manner because we're all human.
Mm-hmm.
And it's really important for me as a medical director to support that so that people do come forward when they do make a mistake, because it is about a mistake. It's not about screwing up so much. It's easy to say the words,
Mm-hmm.
and that's how it feels. But it's really about, and a bigger concept is just culture.
Sure.
And it's understanding that people want to do the right thing. There are very low level providers in everything, be that EMS, nursing, there's good janitors and there's bad janitors. And everybody has good and bad in their vocation.
Mm-hmm.
Question is, how do we make the bad safe and the good excellent?
How do you do that?
The way I like to think to do it is to spend time with people, talk to them, see what drives them, and try to find something that spurns them to grow and to have a goal. And if they have a system around them that supports them, they're going to do better.
That's key. I think people get so frustrated because there are medical directors and systems that you have paramedics who have been there for 15 years who wouldn't know what the medical director looks like if they lay eyes on them. They just know the medical director's name from being on their command form. And then something happens, like an RSI goes sideways, and then there's a blind directive that comes out that says, moratorium on rapid sequence intubation, signed Dr. Medical Director.
That's normal.
Yeah.
That's very normal. In fact, most people, it's funny when I talk to people that we hire, and I meet everybody usually at least twice in the onboarding process on their first day. And then for all the ALS providers, I meet them and sit down and usually have a meal with them, or at least sit down for a little bit, an hour or so,
Mm-hmm.
and have a conversation about process and clinical care for all the ALS providers, because I don't want the first time that they see me and sit down with me being that they're in trouble. I want them to know that a positive interaction is exactly what they should anticipate from their clinical leader.
Yeah. Whether it's a positive interaction or a quote unquote negative interaction, like something went wrong. I think, though, that as first responders, we generally think the worst. We catastrophize. So if we have an encounter with the medical director, we go into it thinking that it's punitive and that it's disciplinary.
That's the normal history of that conversation.
It totally is. Like the internal affairs, QA, we all think the worst. I am in trouble. I had a couple years ago at my flight job, we RSI'd a guy, trauma. The RSI procedure went absolutely flawlessly. In fact, I still maintain you could film us doing it and use that as like a model for here's how you conduct an RSI. Problem is, the patient coded and died 10 minutes after we RSI'd him.
Well, that happens.
It does happen. And I got a phone call from our boss on the flight team and said, hey, the medical director wants to meet with you about this case. And automatically, you're catastrophizing, you're thinking the worst. And as the paramedic, you're already thinking things in your head like, fuck this guy. He's
already
I know
evil.
he was a paramedic 20 years ago. He thinks he knows everything about EMS and, he's going to tell me I did this wrong. And I went into it. I was all like, ruffled up, ready to go and argue. And it was one of the most constructive educational conversations I've ever had.
That's awesome.
He was like, he said, I have been in your shoes as a paramedic, as an ER physician. I'm not saying you did anything wrong. I'm just saying, here's lessons I've learned. Maybe you want to consider this, maybe defer intubation on this guy. And of course, I was pissed off when I got off the phone because of my ego. But as I've said before on the podcast,
I'm glad you don't have a big ego.
Yeah, I know, not me. But I still like a half-hour ride to get to the flight base, and I'm getting like sinking in my seat a little more as I'm driving, because I'm like, man, he was absolutely right. It was a great conversation.
But that's how those should go. It should
100%.
absolutely be, hey, you had something bad happen. And I have people call me probably once a month with a medication error.
Okay.
And it's not the same person all the time, which is the best part.
That's good.
And usually it's, I gave this drug versus this drug. And the question I always start with is, are you okay? Because a lot of times people think that the patient has to be first. And I actually think our staff has to be first.
That's a novel concept.
If we take care of our people, they'll take care of our patients. So the very first thing I always want to make sure is that our people are okay. Because whatever happened to the patient's what happened to the patient.
Mm-hmm.
But if we take care of our people, they'll be more interested in taking care of the patients. And I one of the things I learned as a SWAT guy was if you take care of people, their families will support them doing their job better. I had a nurse one time look at me and say, "Hey, Bert, I'm really glad you're there because when my husband goes through the door, he used to really worry about what happens to him. But now he knows that he's got good medical support. So he only pays attention to doing his job." And I think that takes a lot of stress off the whole system. It's if you support your people, if you let them know that they're supported and that mistakes happen and that we can learn from them, then they're going to be able to spend more time worrying about their job and doing the right thing versus protecting themselves.
Yes. Yes, that is massive. I've mentioned her a million times, Alex Jabber. She's a paramedic who obtained her doctorate in psychology. I don't exactly know what she does. She specifically told me I am not a psychologist.
She's a head shrinker of
not
some
a
sort.
clinical psychologist. I don't know, but she said that, obviously she studies the PTSD and the CISM and all that stuff, but she said administrative betrayal is a huge source of stress for first responders.
Mm-hmm.
I was just on a podcast. I got to know these guys. They're cops out west. They have a podcast, Tone Alert. And the one was telling the story. He got into a scuffle and got shot in his leg.
Okay.
I think it took out his femur. I don't exactly remember. Oh, yeah. He said his femur was like in a million pieces. But he said he is sitting in the trauma bay, panicked, not about the bullet in his leg, but about the kind of trouble he's going to get in because he was in this encounter.
Yeah.
Because somebody shot him.
That happens.
Yeah. And that's just the culture. And I mean, it's good to hear that there are physicians getting away. Not that I think some were like that. I don't want to make it sound like that, all the ER physicians were out to get us, but
there's a culture change happening.
Yeah.
I think in the last 10 years, it's started and it's only now gaining enough energy to be recognized. And a lot of that comes down to board certification in EMS fellowships, because, circling back, I do believe that physician oversight is important in EMS, just like it is in the emergency department or anywhere else.
Can you spell out, this is a simple question, I think I know the answer, but I see that comment enough. We didn't get ER doctors out of this. Like, can you spell out why we need physician oversight? Because you were a paramedic for years before you went to medical school.
Only 13 years.
It's enough time.
The physician education is different. It's about understanding more, and I don't want to sound crazy, but it's the holistic understanding of the entire system and where the patient falls within that.
That's huge.
When I was at that community hospital that just closed because of issues.
Check out my last podcast if you want the name.
It's crazy. The hospital that used to be a trauma center and saved lots and lots of lives every year. The EMS staff came to me one day and said, "I don't understand why these doctors are so stupid. We teach ACLS for everybody, and we know all this ACLS, and they don't know any of it." And what I realized when they said that to me is that the paramedics are resuscitationalists. They understand acute care interventions and do them more than everybody else. Nobody does more cardiac arrest care than a paramedic from a professional standpoint. So when they teach ACLS, they have more understanding than the radiologist or the family medicine doctor or the internal medicine doctor. And they're conceptually on par with emergency medicine physicians because we manage the continuity of that. But what the paramedics at that point didn't appreciate, and what we actually had phenomenal conversation around is, I asked them, well, I don't know, what cancer drugs do you think somebody should be started on for a small cell lung cancer? And they're like, well, I don't know anything about that. I'm like, well, see, that's what the oncologist does. Hey, how many REMS is safe for radiation treatment for that tumor. Well, I don't know. Well, that's what the radiation oncologist does. And realizing that EMS is a component of medicine.
Mm-hmm.
And with that comes, how do you fall into the overall care of patients? And that's where physician oversight is important, is it's what are the pieces that come together to care for patients? What are the interventions? What are the medications? And one of the things that comes with being a physician is understanding that failure is something that happens and understanding where the risk is, because the risk is the most important thing with all of it. You asked about RSI and paramedics, and should paramedics be able to RSI? And the answer is yes. But there's a comma there. Which paramedic should intubate? Which paramedic should give RSI? Which paramedic should be able to manage an invasive line? There are multiple components of being a paramedic. And one of the pieces I would love to see is paramedic not being a single certification. I believe in the advanced practice paramedic concept. And that would be a more inclusive critical care and non-critical care intervention. So making the paramedic more of a mid-level than they already are.
Do you see that coming?
I do. The new protocols coming out in Pennsylvania for tactical medics starts pushing that a little bit more.
Okay.
And I think it's something that's going to happen throughout all of healthcare. We have PAs and NPs in the hospital. We don't have an equivalent in the field.
Oh, you're bringing up the paramedic practitioner thing. The way it was proposed, I was against.
But that's the idea of the words are almost immaterial. It's what's able to happen and how do you get people there. Physicians are at the top of the food chain.
Mm-hmm.
It's the way that medicine is structured. That doesn't mean that paramedics should be, quote unquote, put in their place.
Mm-hmm.
That means that they should be a part of it. Paramedics save more lives than probably everybody else because they make those emergency minute interventions. That doesn't mean that they're at the top of the food chain or the bottom of the food chain, or they're the most important or least important. They're a part of it. And so it's about coordinating resources, and it's about supporting people's growth.
I got you. Okay. One of the things you and I discussed when you got back from the NAEMSP conference, I'm trying to think how to word this in a politically correct way. One of the frustrations from my perspective as a paramedic is, and I love ER physicians. They have molded my career. The ER doctors that I came up with, I owe them a debt of gratitude, but it is very, very frustrating to work with an ER physician that has no concept of EMS or what we can do or what we're in the field. So let's say I call for orders and I just get a blind, no. Now, do I like getting my orders shot down? No, but there's one particular physician I think of. I've spoken to him and he has shot down my orders, and he comes and he finds me and he's like, you were spot on. I just want to let you know, I'm going to be assuming care of this patient. I think I want to go this direction. I just want to let you know, you're right. I don't mind like having great conversations like that, but then
it's about the second question, not the first question,
which is,
so you asking the question you ask the question of, you want to give this medicine, and they say no. Well, that's fine. As long as there's a comma and because there's got to be dialogue.
Yes.
It's, to me, online medical command is not about I want and I get or I don't. It's about a conversation, a consultation where the paramedic is in front of the patient with a plan. And one of the things I've found, I think we've all done it. We've given a report on somebody with a question, and we answer our question when we ask out loud, when we talk to somebody else, because we get a different thought process once we say the words. And to me, a good medical command conversation is, hey, tell me what you see. What are your thoughts? What do you think about this? Mm-hmm. It's a dialogue. It's one of the reasons I hate using radios for medical command, because it's two people talking at one another.
Do you think there should be online medical command?
I think there should be. The question is for what?
Correct.
And I think it should be about confusing unusual cases. Okay. So things where, hey, I've got two different directions I could take with this patient. I can kind of see either direction.
Sure.
What are your thoughts?
Sure.
Because to that physician's point, they're going to be assuming care. And if you've gone down a path that they can't take a different turn on, that can be a problem on the long-term care of the patient. It doesn't mean the paramedic was wrong. Maybe there's a different or better option based upon something that the paramedic doesn't know, or that the physician has a different take on. And the continuity of care is important. It's an issue that happens in the emergency department all the time, where if we start a certain antibiotic regimen, then the in-hospital physicians continue because that was what started.
Mm-hmm.
It may be right, it may be wrong. It's the direction that things take. It's the momentum of anything, that if somebody starts in one direction, it takes a lot of effort to go in a different direction.
Sure.
So coordinating that, and it's true coordination. It shouldn't be mother may I. It shouldn't be, is it okay if I? It's, hey, I've got this case. I want to go this direction. Does that make sense?
I think that would be a phenomenal resource. It is quite, as you know, quite frustrating to be on the side of the road calling for RSI orders, and you have ER doc of the day who doesn't know jack shit about EMS, picks up the phone and, hey, this patient's posturing. They have a pulse ox of 92%, but they're combative.
Aspirating blood.
They're aspirating blood. Just bring them in. You like defer intubation. I'll see you when you get here. And it's like, no, we're 45 minutes out. I'm going to be managing this patient alone. Or on the flip side, you call with some lowball patient. You say, hey, I've assessed this patient. Here's what I found. I would like to release this patient to BLS crew to transport them to your facility. And we're told, oh no, that patient needs to be monitored. So they don't understand. They are taking a paramedic out of the community for an hour and a half, and then the patient goes to the waiting room.
Oh, see, that last part's the part that drives me nuts.
When you arrive.
If a paramedic is bringing a patient to the emergency department, and because the physician said they have to be on a monitor,
mm-hmm.
then that physician should make sure there's a bed for them.
It happens constantly.
Oh, there are certain hospitals in our area that are very well known for that. Yes. Both sides of that.
Yes. At least they don't take the IVs out anymore to send somebody to the waiting room.
Oh my gosh.
They don't do that
anymore. That's a travesty,
anymore.
But I'm glad that there's been some advancement in that. But no, that's the case that one of the things we do with our residents is we sit them down with a radio. It's 2 or 3 residents and 2 or 3 paramedic students. And another EMS physician I work with regularly is the medical director for the paramedic school. And it's one of the coolest things that we do. We have 4 different rooms set up. Each room has 2 or 3 paramedic students and 2 or 3 residents.
Mm-hmm.
And we do cases across the radio when we talk about them. So one of the cases that's always there is termination of resuscitation. Where I think that's really cool is the paramedics will call in, and then there's some question, and then the doctor will say, you know what, I'd feel more comfortable if you just brought him in. So then the question I always ask of the residents is, do you think that the paramedics are going to be trying very hard after they've already called you to stop resuscitation?
Correct.
And they're always like, well, yes, I ordered it. And I looked at the paramedic students and I say, tell me what percentage of effort you're putting forward on this time when you've gone out of your way, you understand the patient has very little chance for resuscitation or a good outcome, and somebody tells you to keep doing CPR for the next 40 minutes to the hospital. And uniformly, we do try, but
we give
not really
CPR
hard.
and epi every 3 to 5 minutes.
Right,
it's
to make
going
the chart
through the
look
motions.
good. But,
exactly.
But the active resuscitation has ceased. Unless the physician says, hey, can you get him here so I can do this? You got to sell the therapy. It's not just, I want to see them.
Or try this during the transport.
Again, it's collegial discussion.
Yes. Yes. It that is another point of frustration. People from outside of where we are, especially out west, get mind blown when they hear, they'll make comments like, wait, you guys have to call for a termination, and
mm-hmm.
wait, you actually transport dead bodies so they can put a POCUS probe on the patient's chest? Yeah, it happens all
right.
the time.
We're actively looking at process to get a ultrasound out to the patient so we can stop transporting dead people.
I think that's better for the patient, and it's better for their families, because
there's another piece of it that gets neglected all the time. There's the community.
Mm-hmm.
We've had a number of emergency vehicle accidents where luckily it's all been the other person's fault, but people have run into our ambulances transporting dead people. And I'm down an ambulance. There's been an accident. It's in the news. It's usually on the front page of the paper of ambulance accident. But I've had hurt people that are now out for a while. So not only do I have injured family members, my family members, our paramedics, but they're injured, they're out of work. Some of them don't come back for a long time.
Mm-hmm.
And it's not for a patient betterment. That's a systems problem. It's not just, the patient's still dead and the family feels bad, but the whole community has lost an emergency asset.
So without just saying the blanket term of, well, more education for the emergency physicians, how do you fix that with the physicians who are going to be giving medical direction to EMS crews?
I look at that in a similar way that I look at onboarding people, and that is dialogue, conversation, relationships. Physicians can be a little stuck in their ways, and as one, I can say we're all a little off at times.
Mm-hmm. So is everybody.
So is everybody. We're especially off, though, I think.
Okay. I mean, you're also a pilot, and pilots are weird. So you're a physician and a pilot.
Yeah, I got a couple
really
of check marks on the
strange.
weird side. But I think it comes down to making sure that people are open to feedback.
Mm-hmm.
That's really the biggest part of, hey, you ordered this. What were you thinking? Oh, well, I was thinking this. And it can't be, again, I go back to the second question. Asking what they were thinking is fine, but saying, would you do that next time? How would you, if knowing this is the outcome, did you make a good decision?
How much does the fear of getting sued play into the decision-making, do you think?
Too much.
Yes.
Whatever amount it is, it's too much.
Yes.
There's all kinds of examples I can pull up of people saying, actually, one of the best ones is pediatric cardiac arrest. I've had a number of physicians say, I just don't know that I could ever allow the paramedics to stop resuscitating a child.
That is one of my pet peeve things, because I don't like pediatrics, but
They're still people.
Dislike children. And I'm a father of little children's. I have coded kids that were my kids' age at the time.
Yes.
And nobody wants to see them die. But as a professional, as you put it, a resuscitationist, you can look at some of these children and be like, the soul has left this child's body. This is a dead body.
Best example I have for that is in a city north of here. One of the guys that actually precepted me when I was a paramedic student called me on the phone and said, I got this kid who shot himself in the head. He's like 4 years old. The cops handed him to us as we got there. He's in the back of the ambulance. And where we work, if you stop resuscitation,
it's going to create an international incident with the police and with
a degree, the coroner's office is the concern, because according to the law, wherever the person's declared dead is now the scene.
Okay.
So I said to him, well, do you want to continue resuscitation in the hospital, or you want to stop? And he said, this kid's dead. It's the wrong thing to do to transport. I said, great. I confirmed where he was, and I went to the scene, and I talked to the staff.
Okay.
Because that's really traumatic. But if they went out of their way to call medical command to terminate resuscitation on a child with an injury incompatible with life.
Mm-hmm.
And I have infinite respect for that.
Sure.
This is just to have someone who had precepted me call me for that discussion. Sure. That's a lot of weight. And where I always take it back to is, if someone's willing to start that conversation, then they've already come to the point that they're comfortable with that outcome.
Sure.
And we should support people in making that decision, because if it's not going to change the outcome of the patient, there's a lot of times that the mental health aspect for the provider is a huge piece of it.
Mm-hmm.
Because the last thing I want this crew to do is to, for the next 10 years, have that kid's face in the back of their head.
And then you're going to expose more people at the hospital to
the
this
whole
4-year-old come in with a bullet hole in the head. And
yeah, and we've had that a number of times where in the trauma bay we'll have a 45-minute resuscitation on a patient who has exposed brain and is in asystole. And my question is always, who is that helping?
Yeah.
we've now involved an extra 50 people in PTSD concerns.
Yeah, that is a fact. So going back to, you brought up, we got into this dovetail discussion of dead kids with the concern of being sued. And you said there are medical control physicians who are like, oh, if it's a kid, I could never like bring them to
I couldn't let them say dead.
do a termination. That, and I'm not excusing them. That is a more uncommon situation.
It is
But,
uncommon.
like, how do you deal with the everyday physician who picks up the phone, who's concerned about being sued? Like, oh no, that 19-year-old with chest pain who's got a perfectly normal EKG and they have a cough. Oh no, they have to come in because the physician's worried if something goes wrong, I'm going to get sued for issuing those orders to the paramedics.
The great part is EMS in our region is held to gross negligence. And that's a really nice thing to be held to, because that means that you intentionally did the wrong thing.
Can you elaborate on that? Just because some
Absolutely.
people may not totally get.
So there's different legal constructs, and I'm certainly not a lawyer, but the understanding being that gross negligence is the idea that you purposely did the wrong thing without due regard for the patient. So you didn't care what happened to the patient. You just did whatever you wanted to do, and knowingly did not put the patient's best interest at heart.
Okay.
A 19-year-old with no prior past medical history with chest pain has an incredibly small cardiac risk.
I had this morning. This is why I bring up that example.
Okay. And to me, if you have a negative EKG on a 19-year-old with chest pain who has relatively normal vital signs, the risk is in the occult STEMI, which, well, you just looked for it. It wasn't there. So I just don't see risk there. I don't. And there are a lot of people who are very risk adverse.
Yes.
And while I appreciate that, it has great systems implications. The utilization of resources, manpower, those are big deals. And the idea of, well, I just want you to write it in. I was asked, well, but for what? What's your concern? And the concern needs to be patient-centered, not provider-centered. So to me, if you have a paramedic, does a 12 lead, it's negative, the rest of the history is unremarkable. I mean, it's certainly different if you're going to tell me that it's a 19-year-old with Marfan's who recently had a aortic graft or something like that.
They describes the pain as
it's tearing across my back.
Yeah.
My heart rate's a little high, my blood pressure a little low.
Yes.
Sure, but you got your run-of-the-mill, I had some chest pain. It is what it is.
Okay. How do you, just overall general question, how do you feel emergency medicine as a specialty views paramedics?
What a variable answer. I can tell you where I work full-time right now, it's very collaborative.
That's how, and I only use names when I'm saying good things on the podcast. I feel like that's how Christiana Care in Delaware is.
That's how
very collaborative.
I think you'll find that most higher functioning systems utilize paramedics in their emergency departments, and they have a relationship with EMS services where they have a bidirectional flow of information and feedback. It's not supposed to be adversarial. If it's adversarial, it makes you wonder what they're covering up.
It does. I did a reel on a statement that I don't think he's the current president of ASEP. I think he's either the immediate past president or whatever. All you doctors get titles for everything. Like the Grand Poobah Emeritus Director of, that's one of the things
so funny.
That's one of the things my dad said before he retired. He said, everyone has got some title, director of some bullshit, chair of blah, blah, blah.
Yes, there's a lot of titles.
But he's something at ASEP.
Okay.
Like 15 different like exalted titles. And he said in a speech that EMS is the greatest, what did he say? Greatest fraud ever put on society. There's virtually no evidence that EMS does anything to improve outcomes. And to me, that's kind of like, do we need outcomes to show the value of EMS? Or is it kind of one of those things, do we need data to show that ice cream tastes good?
Or the parachutes work.
Or that parachutes work. Dr. Mark Peel came on the podcast and talked about that with the data on blood. Do we really need an RCT to show that? But so I really, like, I don't take offense to much. I get pissed off by stuff, but I did take offense to that And my real was, sure, maybe he's right. There's no data that shows that we make a difference. But is there any data that shows that emergency medicine as the portal of entry to healthcare for most people makes any bit of difference? Do you need that
So one of the
data?
one of the questions I would ask you is, have you ever held a patient's hand?
This week, the other night, it was a nursing home call,
Yes.
87-year-old septic shock, DNR, DNI. They were shipping her out. This lady she was dying. She was absolutely dying. She was miserable. And she died a couple hours later. And her daughter was pissed because she met us at the hospital. She was super nice. And she's like, I didn't know she was this sick. Like, I would have just gone in and sat with her, like, and had
That's real.
my brother and sister come in. And now, like, we transferred her to die on an ER stretcher
Yeah,
in a busy urban ER.
I got to tell you that's how I got COVID. Some nursing home patient was in the hallway because everybody was drowning in patients, and she was crying that nobody's touched her in 3 weeks. So I gave her a hug. She knocked my mask off and she coughed right in my face. It was perfect, kind of like you and Croup.
Yeah, exactly.
But you know, there's no data to say that old lady crying on my shoulder was life saving. It wasn't. She was going to die. We all do it. But really, what it comes down to is sometimes relieving suffering is what we do,
Mm-hmm.
and we're going to have patients that die in front of us.
Mm-hmm.
And sometimes all we can do is provide them a nicer way to go.
Amen. That is one of my criticisms with evidence-based medicine. All about evidence-based medicine.
Absolutely.
All about it. But it focuses on long-term outcomes too much and mortality. Like if they're all dead now, but let's say my grandmother fell and broke her hip.
She probably wants some pain medicine.
If BLS shows up and puts her on the stretcher, that has zero bearing on her mortality or outcome. Absolutely none whatsoever.
Completely agree. No need for paramedics if you're only looking at that.
Correct. But I would much rather have a paramedic come, give her a hit of fentanyl, and keep her comfortable on the way to the hospital.
Yeah. And that's not a quantifiable metric in anything other than pain scores and the other things that, depending on how you look at metrics, don't matter. Because it doesn't make you live longer. It doesn't make your surgery go better. There's no difference in complications. But boy, does that make a difference to the patient. Boy, do they appreciate it more. And, you know, for the administrators listening, you'll get a whole lot of attaboys and your team did a good job when somebody goes out of their way to make sure that their pain is handled.
Oh, yeah, totally. Totally. I've always, even like not like invasive or pharmacologic pain management, I've always trained people, even EMTs. If you don't know what you're doing, just make the patient feel comfortable. Take the time to put an extra blanket on them. The family will write a letter about just how wonderful you are. I have seen more than one paramedic who I would consider to be a weapon of mass destruction, just incompetent, but letter after letter from families because he is.
Would you like me to fluff your pillow? Would you like a blanket?
The sweetest, nicest person.
And, you know, VFib doesn't necessarily need to be shocked as long as we can stroke their hair and tell them they're doing okay.
Yes, 100%. Okay. All right, we did a bathroom break, so we're back. And as the kids' YouTube videos say, we're back. I want to talk about treat and not transporting. Because I have always questioned how much help are we doing people, bringing them to the ER to sit and wait for hours upon hours upon hours. And we can treat at the point of injury or illness. And then they see their primary care provider if they have one.
See, that's a great topic. And, you know, we talk about risk and people's concern for litigation. And there's a lot of concern for litigation over this one.
I feel a little, I agree, because this is one of those areas where the physicians have quite better training. So we live in a bubble as EMS providers.
Yes.
Where we are trained a little bit about a whole lot of different little things. The novice paramedic may respond to somebody with, I don't know, let's say leukemia. And they say, oh, you know, I just don't feel well. I feel run down. You know, my temp is like 100.4. A novice paramedic may just go, oh, well, you have cancer. Like,
it is what it is.
Yeah, you're going to feel like crap. And I think that an experienced paramedic may look at that person and be like,
"Oh, they're sick."
yeah, like you're sick. Like your body can't fight this infection. Like you need to go. So I do think that there is some high risk of
So one of the things that kind of came out
danger.
of we were talking about type codes at NAMSP and talking about what calls can wait,
Mm-hmm.
because obviously we don't have lots of extra resources running around. And one of the things that came out of this study, and I don't remember the specifics of it, that there are some BLS calls that can't wait, and there are some ALS calls that can. So
I have always talked about the BLS ICU patient.
Yes, it's a real thing.
It is a real thing.
And what you just described there, is it blast crisis? Is it, acute kidney injury with hyperkalemia?
I have put patients on the ambulance, and now I'm going to get all these like high and mighty paramedics saying, I can't believe you would do that. I have sent patients BLS, and I've told the BLS crew, like, don't be surprised if 2 hours later you see a helicopter landing at the ER to pick this patient up.
Right.
Because they need to go for a liver transplant consult.
There's nothing that you as a paramedic are going to do to intervene on that.
100%. Like vitals are stable. They don't even need a fluid bolus, but they need a freaking specialist.
And those are different priorities. We often hear about the miss by EMS.
Mm-hmm.
There's the other side, which is when EMS is correct. And you talk about levels of service. And to me, the advanced practice paramedic is really where I see the opportunity to make that distinction about who doesn't go to the hospital.
Okay.
Because if you've been doing this job long enough, you've made some mistakes and hopefully you've learned from them.
Yes.
And you've seen not sick patients who are really sick and you missed something.
Yes.
The longer you do it, the more, and you get feedback. And that's why this is, from a systems perspective, is important. You get that feedback of, hey, that guy with that leukemia stuff who had a fever and his heart rate was 110. Yeah, his hemoglobin was 4, and he was acute renal failure, and he was incredibly sick. And just because somebody else in the house had the flu doesn't mean that he has the flu and that you can leave him there. It's understanding how patients fall within systems. And the entry-level paramedic doesn't have that knowledge base. And I think it's important to look at that distinction between the entry-level paramedic and the experienced provider. And that's where a lot of the advanced concepts are going. And it's one of the reasons why I'm always hesitant to hear, well, we're going to come up with a paramedic protocol for. Because we have to define which paramedic that's for. Because I have some phenomenal entry-level paramedics who don't have the experience, but then I've got some experienced paramedics that don't have the knowledge.
Or the wisdom.
The wisdom's the important piece. And we all have blind spots. It's important for us to know where they are.
Mm-hmm.
So for EMS initiated refusals, or whatever term people want to use for it, there's a role for that. There's a role for the nausea and vomiting, give them a liter or two of fluid, because I know that that's never happened in an EMS station before. I may have been anyway. But there's a role for that. And one of the concepts I've put out there, and it usually gets frowned on, but the idea of variable risk. We all like to think that we provide every patient the same level of services at all times.
We don't.
And you talked about taking patients to the waiting room. Every waiting room has variable numbers of people in it. When we have a hospital with 100 patients in a waiting room, they're not providing the same level of service when they have nobody in the waiting room. So if we're going to talk about systems of care, maybe the best place for that patient to get care is in their home at the end of when that system's overburdened. And some service will say, well, we're overburdened, we can't spend 15 extra minutes on the scene or 30 minutes with the patient. And I'd make the argument that that's the best involvement of time that they could possibly have.
Sure.
Because by spending 30 minutes with the patient now, giving them some fluid, reassessing their vital signs, making sure that they have follow-up, well, you've saved the patient a financial injury, which is oftentimes overlooked. People say, just go to the hospital, it's free. Nothing is free. There's going to be a bill. Whether it's written off or not isn't something for the EMS practitioner to make the decision on.
Correct.
That's made by many people later. So we have to empower the paramedics to make decisions. And that should be done, to me, again, I'm going to put the physician in that. That should be done in consultation with the physician to understand systems, resources, and availability, because they are variable. You got a healthy person who was diagnosed with the flu at urgent care yesterday, has been vomiting for since then, a little hypotensive, a little tachycardic. That may be someone that's appropriate to be treated at home.
Mm-hmm. But that 1 out of every 8,000 is going to have mesenteric ischemia.
They will. There is no such thing as a 100% system.
Do you ever, is there in physicianness, I know it's not like Lean Six Sigma, but is there an established, not okay to miss, but is there an established like miss rate that is kind of considered the normal is that we will miss?
1% is usually what's put out there, depending on the disease process.
Okay.
That being said, there are some disease processes that are acknowledged that will have a 50% miss on the front end.
Mesenteric ischemia.
There's numerous ones where the initial presentation may not be severe, labs may look good, and disease progression is a real thing.
Mm-hmm.
People do get sicker. Sometimes, just because somebody comes in with a runny nose, and COVID is a phenomenal example of that. How many people had COVID, then it was very mild, and how many people died from COVID? It's a variable disease. And that you had COVID early on didn't mean that you were going to die. There was certainly more of it, but it's who's the patient, what are the risk factors, can we provide them the resources we have, and then see, do they bounce back? Do they call again? And the BLS providers see this all the time. Granny Grump falls, they assess them, they look good, they don't want to go to the hospital. You come back 4 hours later because they fell again. Most people will be like, hey, you fell twice, you need to go to the hospital. And, is that a BLS call or an ALS call? Well, that's a BLS call, but if they've fallen twice and they can't get up, the chances are they actually have a real metabolic issue going on. So it is a BLS call that's going to likely end up in an admission and might end up with them in a nursing facility.
Yes.
Because of an ongoing medical problem.
Yes.
But we also have to respect people's individuality with the ability to make decisions that we don't agree with. Sometimes patients don't want to go to the hospital.
Correct.
And that's okay.
And I said this on the last podcast. It is not our job to force people to make good life choices.
Oh, they're going to make many poor choices.
That's
why we're employed.
Yeah, exactly. Job security. But if we have appropriately explained the risks, the patient understands, and you can't just go through the riot act. Like if somebody is, I'm trying to think how to best put this. If somebody's an absolute moron and you can tell they're uneducated, explaining to them like, well, sir, you could have acute mesenteric ischemia and like your superior mesenteric artery could be occluded. Like you've just gone through the motions.
You're using words.
You have to ensure that the patient understands.
You got to tell important things. You might die, be permanently disabled. You never
expensive surgery. I tell people all the time with hospital
I tell them
destinations.
they might never have an erection again.
That's a big one.
That's a really big one for the dudes. Now, when I say it to the women, they always laugh. But this is the you talk about the endpoints that people can identify with. You might be on dialysis. You might be on a ventilator. You might never be able to eat again. You can figure out what their complaint is around, and you tailor the comments to that. And some of them are tongue in cheek, but some of them are real because we don't have the answers.
Yeah, I think the whole endpoint of you might die is poor because people don't really consider that. They don't consider their own mortality.
It's not a real thing.
But if you tell somebody, hey, you might not be able to use that arm to eat dinner anymore, that's for a lot of people going to be the thing that goes like,
oh, I like my arms.
Crap, I might like actually have something wrong with me.
Right. And those, to me, those are the risk factors that matter. To say you might have an intracranial hemorrhage doesn't mean anything to the drunk person.
Squat.
And I don't have a fucking
right. So where does that go? I mean, it goes. You might be having a bleed in your head where you'll never be able to eat or drink and you'll live in a wheelchair. We have to meet people where they are, and we have to talk at a level that they understand.
Do you see refusals going anywhere? Because I think the current way we do refusals is absolute bullshit. I think running it by a med control physician is a nice box to check. You might be able to give some better insight to the patient. So if you speak to them, and then the refusal form is not good as the paper it's written on.
I think that the refusal form is a good starting place with the understanding that
It's a legal hurdle.
It is
It's
a legal
just
hurdle.
something the lawyers have to jump
well,
over.
though what I like it for, and I was part of the discussion around this on the front end, it gives you physiologic norms that if people are outside of, that you should be, it's more of a stop and think.
Mm-hmm.
And whenever somebody calls me, my first question is what gray box got checked?
This is the Pennsylvania
Yeah,
form.
the Pennsylvania form has little gray boxes,
Yes.
and if you check a gray box, you call a physician.
Those are the goddamn it boxes.
Yeah.
That's what I call them, where you're filling
Well, they
out,
should
you're
be
just like,
damn it boxes. To me, where those are important is that gives me as a medical command physician something to talk around. Because if you just give me if you just present the patient, I don't know what I'm listening for. But if you say like, hey, they were in a motor vehicle accident 15 minutes ago. It was their dad's favorite car. And the kid's 16 years old, heart rate's 120, exam's negative. I'm like, great, have a good day. But if you're saying, I've got a 72-year-old who's got a bruise on their abdomen, heart's 120, very different.
Yeah.
But I know what I'm listening for.
yes.
So the heart rate is different in different people. I think that some of the online medical command stuff should go away
Mm-hmm.
because I think that it comes down to empowering people to make good decisions. The backside is there is a risk in some of this.
Sure.
And I do think that sometimes where I think that the paramedic should be calling or EMT should be calling for medical command for refusals is when they disagree with the patient.
Okay.
Hey, doc, I got this guy. We've going back to Granny Grump, hypoglycemic 3 times in a row. They're on an oral agent. They haven't peed in 3 days. This guy's got to go to the hospital. And he refuses. But now he's awake and oriented. He says all my stuff and he doesn't care that he might die. Do you want to maybe talk to him? Maybe they'll listen to you. That's a conversation. That's teamwork.
Mm-hmm.
It's not mother may I.
Mm-hmm.
And that's where I see the benefit of calling for that because it's collaborative. It's using resources. I can't tell you how many times people will listen to the physician. Well, the doctor wants me to go to the hospital. And the medic's like, I spent an hour with this person.
Oh,
You spend 1 minute
one
and all of a
second.
sudden they
Okay, I'll go.
it's
Like,
crazy.
oh, yep. What
And
do
I'm
I?
not special. I was too stupid to stop going to school. So I see two sides of that. And yeah, the check boxes are a pain. And I get that.
Yeah.
But it also gives you something to think about of, wow, so there's risk in this. And
Yes.
I to me, that's the purpose of that refusal form.
Okay.
That's the purpose of the call.
Okay.
It is a pain in the ass.
It's not so much that you think that there's any legal protection if the patient signs it.
Oh, no.
Yeah. Okay.
Well, no. Well, there can be.
There can be.
But more importantly, it's did you evaluate this and did you acknowledge that there was an abnormality? And if the answer is yes, yes.
Okay.
Patients can make poor decisions, and they do every single day.
All the time. Usually that's what led up to them being in this situation
And here
in
we
the
have
first
it.
place. Do you have any other thoughts on the treat no transport?
I think it's going to continue to grow. I think that it's one of the big pushes that's being worked on from a legislation standpoint is payment for that. That's been a big issue for transporting cardiac arrests, for diabetics, because the pay model, God, I'm sounding like an administrator here, but
But you're right.
But the pay model is through transport, not through the
Yes.
treatment. And if we can change the payment model to be about the treatment and not the transport, I think it'll be financially beneficial to the organizations and organizationally and from a system standpoint, much better because we won't have people hanging out at hospitals to be dropped off for nothing.
One of my friends who is he's a very smart guy, and he's going to listen to this. He's going to know exactly I'm talking about him. He was a high level administrator in another state government. And he is convinced that all this push to limit paramedics is because physicians want to bill for the things that the paramedics are going to do. You brought up payment, so it made me think of it. Do you think that's a conspiracy theory? Do you think that's tinfoil hat stuff?
I think there's some concern around that.
Okay.
There was a lot of great example again is COVID, where there were a lot of treat in place protocols that were put out and very few were utilized because the emergency departments had no volume.
Nobody.
So
And then it all changed.
And then it all changed. Boy, did that hurt. But we changed how we did things specifically around if we were inundated with patients, it's okay for them not to come. But if we're not inundated with patients, there's a business side of this.
Yeah.
And you know, a lot of people are protected from that, but without call volume, without bills, there's no payment. Without payment, we can't pay paychecks, and without paychecks, a lot of people aren't coming to work.
Mm-hmm.
And so it's understanding both the service and the business side of what we do.
Gotcha.
It's ugly.
It is ugly. Business and healthcare is ugly. My best friend, he was a state trooper and he went to night classes at law school, and now he's a big time corporate lawyer.
Smart guy.
And yeah, and there was an industry we were talking. What industry were we talking about? It was some type of like high level corporate, like Wall Street type stuff. And I was like, that sounds super dirty. And he was like, it is dirty and it's nasty and it pales in comparison to healthcare. And I was like, damn.
Yeah, the big issue in healthcare right now isn't the politics, because there's politics in everything. It's that there's no money. It's that there's no margin. And as one nun said, without a margin, there is no mission. So we can be altruistic and provide all the free care we want, but at some point that's going to come down to the fact that we can't put food on our tables.
Yes. Yeah. Well, I've taken up a lot of your time. Do you have anything else you'd like to talk about?
No, I think that you've got a great platform here.
Yeah,
you've had some phenomenal people on. And as a EMS physician, I really think that listening to paramedic podcasts is one of the most important things that we as EMS physicians can do to understand what it is that our paramedics are thinking, the clinical concerns that they have, and just what's going on in the world that we don't interact with regularly because we have different jobs.
And you guys, to throw the docs a bone, because I like to do that from time to time, as much as I bitch, you guys don't have, like you said, you need to put food on your table.
Yeah.
You have to see patients. The ERs are stressed. The second you walk in the door to 2 hours later after your shift, when you can finally leave, you're working. So it is easy to say, oh, the medical director's not involved, but you got to balance your time. And
yeah, I only do about, I'm compensated 10 hours a week for EMS medical direction.
The full-time medical director thing is not as big as it should be.
No, and I only do about 30 hours a week of EMS medical direction, 40 hours a week. And most of that's volunteer, and that's to take care of the people in my community. And I'm much more involved than many other people. And the reason I say that is there is sacrifice being done by many physicians.
Mm-hmm.
And it's because what happens in the street matters, and good medical direction is really hard to come by. Somebody who's involved in the service and actually cares. You know, it's easy to put a rubber stamp on something and say, just go do it.
And collect $100,000 a year.
Yeah, I don't have that problem. I got to figure out how these people do that. But it's a difficult position to be in to try to make sure that everybody gets taken care of in a fiscally responsible manner.
Well, amen. Doc, thanks for
man.
coming on.
Appreciate it.
Drive you back to the airport.
Yay.